Kia ora tātou, ko Bruce Arrell aho. My name is Bruce Arrell. I am the director of the Goodfellow Unit, and it's my great pleasure tonight to introduce Professor David Kuhl from the University of British Columbia. I've known David since 1987 when we worked together in the family practice unit at Vancouver General Hospital, and he is the only international speaker we've had speak twice at a Goodfellow Symposium as a keynote. And this is his first webinar. He's done podcasts for us. So many of you will have come across his work before. So he started off, he trained at McMaster University, where I did my family medicine program, although we weren't there at the same time. He then did family practice in Vancouver, got interested in palliative care, and worked at the palliative care unit at St. Paul's, where he set up an HIV unit. It was the first one, I think, in North America, from memory, David. Then he got interested in psychological support for hospital teams. And so I was working at St. Paul with teams that weren't functioning very well, and then got interested in the mental health of men and boys. And that's led him to his current interest with his NGO called Blueprint. And he'll explain tonight how that term came about. There's quite an interesting story to that. So, David, welcome to the Goodfellow webinar. It's great to have you on.
It's great to be part of this, and I feel very connected to Auckland, to your program, and to New Zealand. So I'm only sorry that I'm not there in person, but I am in spirit.
We've had a lovely summer day today, so I think I know how much you like warm weather, so I think you'd be basking out in the sunshine today. I wonder if we could start, David, if you could just tell us a little about your own journey, because I think that has shaped how you got into the field you're in. I guess it shapes all our.
Yeah, no, I'd be pleased to. But before, while you had a wonderful summer day, I just came in a few hours ago from shoveling the snow on our walks. So we are quite in a different climate than you are.
Yeah.
Uh, I'll combine in terms of how I got here. I think that there's a feature that's very personal and then also professional. And that I grew up in a home on the prairies, and my father was bipolar, and he was bipolar too. So he had long periods of very severe depression and often lived in considerable anguish in terms of his own state of mind. So I grew up in that environment. And when I was 5 years old, my grandfather on my mother's side took his own life. And you don't tell a 5-year-old that grandfather, I'm of German background, so it would be Opa, that Opa took his own life. You tell your child that he died in his sleep. And so I didn't really learn about the cause of his death until I was 16, which then caused other issues because I felt that if my parents were lying to me about my grandfather, whether they're lying to me about other things as well. So I think those are the primary features from my personal background that brought me to the work I'm doing. And I'm not surprised about the work that I'm doing. But then as I got my training in medicine and became a family doctor, I also became very aware that often the mothers would come, and the mothers would come with their children, and the fathers rarely came. And when we first talked about this, I told you about a story where a young father came, and I was very fond of his family, of his kids, and I was a little surprised to see him, but he was concerned about uh, a sore throat that he had. So of course I was pleased to see him. But then just as he left with his hand on the doorknob, a classic doorknob question, he turned to me and basically said, "I'm effing my wife's best friend." And I realized, pardon the reference, but that is what he stated. And I realized he was full of anguish and didn't really know what to do. So, and I also realized that while I had some training in counseling, that I didn't have the capacity to begin to process that with him, but I could connect him to a psychologist that would help him address the issues and concerns in his life. And then I went on to palliative care, and as you mentioned, we were one of the first units in North America that provided care for persons with HIV and AIDS. And many of the men on the unit were younger than I was. I was about 35 at the time. And I had done all the training I could do around of life care, which was focused entirely on cancer at that time. So that the work we were doing with men with HIV and AIDS was very new, different culture, different disease, no treatment when I first started, a very anguishing way to die. And I'll just tell you a brief story about a young man who came to the nurse's station one evening when I was actually just doing my last charting for the day, and he asked if he could use the phone, and I uh, lifted the phone up and put it on the top of the counter so that he could use it. And he said, I need to call my dad. So uh, I was sitting frightfully close to the phone, and I could certainly hear him, but I could also hear the responses of his father. So he phoned his dad and he said, Dad, I've got three things to tell you. First of all, I need you to know that I'm gay. And it was silent. There were no words. And he then said, and I have AIDS. And again, it was very silent. And the third thing he said, and Dad, now I also need to tell you that I'm on a palliative care unit, which means that I'm dying of AIDS. And the silence was screaming, but there were no words. He put the receiver back on the phone. It was before cell phones, and he walked to his room. That had a profound effect on me because the way that care for men with HIV happened in Canada is that the provinces from central Canada and western Canada, of which there are three besides BC, many of those young men came to BC because of the care they got, and they came to St. Paul's Hospital because it was situated in the community where many of them lived. And what was really powerful was the fact that many, many mothers came to the bedside of their sons. Very, very few fathers came. And again, it resulted in my some self-reflection around uh, would my father come? If it was me, would I come? How would I respond to a child with HIV and AIDS? This was in the mid 80s. And would I how would I address the issues? So all of those features were sort of planted seeds to where I was headed. And then because I was working in palliative care, I decided to go back to study psychology because I really wanted to look at health through a lens that wasn't necessarily pathological. So I went the route of counseling psych and really wanted to understand what is it that affects us? How do we relate as families? What happens when there's tragedy, when there's illness? How do people respond? And the supervisor for my doctoral studies invited me at that time to be involved in a study in creating an intervention for men in the military and who were in transition from military to civilian life. And that's when I became more familiar. I was exposed to PTSD. They were all traumatized, and we actually created an intervention for them. And interestingly, the first question they would ask after they had addressed their trauma was, could you help me be a good dad? So you can begin to understand where all of this is going. And after years of doing that work, a colleague, Duncan Shields, and I decided we would focus not so much on the military, but on firefighters and police, partly because of the suicides that were happening in firefighters. And again, it was the same issue around addressing fatherhood after they had addressed the trauma, the grief, the loss. And I learned a lot about masculinity there. I continue to learn about it. And then subsequently have just completed a study where we interviewed 60 people who had a positive relationship with their fathers with the intent to create programs for men who want to be positively involved in their children's lives, either early in the lives of their children, but there's also many fathers lose their connection with their children because they're very focused on work. So we're also looking at programs for men who have retired and want to reconnect with their children. So all of that brought me to the point of actually putting my stethoscope down and saying, I really want to look at the health and well-being of men for the benefit of for them, but also for the benefit of families and communities. Hence the work I'm doing now. A long answer to your question.
I think in a summary, better partners, better fathers would be one way of summarizing that, I think.
That's right. That's right. I guess the other thing I was going to say is we've really uh, like you, I also studied epidemiology and public health, and we really have begun to see that perhaps the neglect in part of men's health is coming to a public health crisis. And so we're working to uh, look closely at the sense that unless the health and well-being of men is brought into the equation of the health and well-being of women and children, the health and well-being of all family members is compromised to some degree. And that if you care for women, you also need to care for men. And there's a huge challenge in how do you bring that about? And how do you change culture amongst men? And I guess that's where our work with firefighters and police officers is becoming more and more relevant because it gives us an idea how to work with men who are very entrenched in quite a conventional, traditional model of masculinity.
Right. So where do we start with this? What's needed to change the equation?
I think what's needed is to have an understanding that an awareness. I think that in New Zealand, men die 3 or possible 4 years earlier than women do. That in terms of mental illness and suicide, there's a much higher rate of suicide among men. And the other thing that has just been brought to my attention in the last year is there's an organization here known as the Canadian Men's Health Foundation who did a survey of mental health of men in Canada, and they found three concerning features. One is that young men ages 19 to 29 have a very high rate of tendency toward depression and anxiety. It, in some instances it could be uh, 6 times higher than a general male population, and there's also higher rates in uh, bisexual men, trans men, and also in immigrants. So we're pausing to say, what do we need to do to address the issues of these young men? And first of all, what might be the features that are contributing to the anxiety and depression? So we don't have any, we have ideas and concepts and understanding, but we're looking to uh, search more closely as to what the causes of that might be.
When we were talking before this, you mentioned social media as the saber-toothed tiger. Would you like to elaborate on why you say that and what impact you think that's having?
I'd be pleased to. I've really come to look at who are we as men? Where does our identity as men and our identity and masculinity come from? So I've looked partly in anthropology for answers in terms of where were men a million years ago, and what were men doing now? What served them well at that time, and is any of that still lingering now? And 500,000 years ago, the features of masculinity, of fatherhood, would pertain to providing, protecting, procreating, and teaching. So that they were teachers. They had to teach their sons and daughters how to survive, how to communicate with each other, how to be in relationship with each other, how they would work together to provide for their families, and how they would work together also to protect their families. And so that in protecting their families, it would be other tribes, other people, it would be wild animals. So as an example, could be a saber-toothed tiger in terms of what they would be protecting their families against or from. And so began to ask what do saber-toothed tigers look like today? And there's not many of them in Vancouver or in Canada. But I began to appreciate the threat to our children and the threat to our families and perhaps even to ourselves has to do with social media, because social media is powerful, it's invasive, it's easily accessible, and it's influential. And it's resulted in us asking the question, uh, who's raising our children? And are they responding to what they see and then believe to be truthful on their phones? And what impact is that having on them? And then also in terms of providing, what is it that children need to flourish and to thrive in their homes. And of course, providing 500,000 years ago would be providing food and clothing and shelter. But there's more than that in terms of what children need. And it's interesting that uh, in the work that I did when I was working with healthcare providers uh, and teams in healthcare, we looked at the literature, we looked at models and theoretical frameworks about what our ideal teams consisted of. And we came upon a whole approach to teams known as relationship-centered care, featured by a Dr. Beach out of Johns Hopkins. And uh, in the work we did, what we realized that teams that flourish, teams that thrive, have some essential ingredients. The teams are safe, team members feel included, there's a high degree of trust, and there's a lot of empathy amongst team members, just working to understand, empathy defined as working to understand the feelings, behavior, and experiences of another person. And the essence of teams that are successful are also have a degree of safety. So, Bruce, if you and I are on the same team, you certainly want to make sure people feel included and so, but part of ideal teams is also conflict. And so that if you and I are in conflict about a particular issue, often the optimal outcome will stem from the conflict if we can maintain it. But we fear conflict, but that's primarily because of our experience of conflict in our family of origin and in growing up. Because conflict is essential a difference of opinion. And I say all of this because those are the same ingredients that would be important in the home. And that if and I will say that I'm focused entirely on fathers. So that's my bias, that's my perspective, that's my work right now. And so that if in terms of providing and protecting, what is important would be for men as fathers working with the children's mothers or their partners to provide homes that are safe to inclusion. If the kids feel included, kids are trust what's going on, and there's empathy. And in the home, I would substitute the word with empathy with love, and there's empathy as a part of love. So that is the home safe enough for the child to be truly themselves? And is the child safe enough that they can trust that what their parents say they will do is what they will do? And what we've learned in our preliminary analysis of the data from the interviews that we've done with the 60, 65 people is that the people who uh, grew up in homes with a positive relationship with their father, the strongest theme has to do with presence. That the biggest gift a father can give their children is being present. And many of the people would define presence as looking at the life of the child through the lens of the child, so that the father isn't trying to recreate himself. The father isn't trying to, the Jungian notion would be the greatest burden a child must bear is the unlived life of the parent, so that the father isn't trying to have their child live the life they didn't have the opportunity to live, but looking very much through the lens of the child. And the people in the participants would also say that they appreciated that their fathers would teach them the values, but they would respect the choices that the children would make as much as they celebrated that the children would be their own person, would become their own adult. And so that those are the features of providing for children and also then protecting them from uh, features of the saber-toothed tiger, which could be regarded as social media.
I was just going to repeat that comment of yours, David, that the greatest burden the child can experience is the unlived life of the parent. Because I've frequently seen adults talking about parental expectations and how that has been destructive of them in their life. It's caused them to feel inadequate, go into fields they may not have wanted to go into, You know, I've had some colleagues go into medicine because their parents wanted them to, rather than that's what they wanted to do, and then they can end up in a situation, you know, feeling quite lost. So I think that's one of the other thing I was just going to say to the audience. David is responsible for that term. If your tears were words, what would they be saying? And that's one I quote quite a bit. And uh, so the greatest burden. So someone's just asked here. The greatest burden a child can experience is the unlived life of the parent. And that comes from Carl Jung, doesn't it?
That's right. Interpreted by James Hollis, really promoted that concept in some of the writing that he's been doing. And the other thing that I would say also with regard to the expectation uh, and self-confidence, you made reference to that. Uh, what we're learning is that emotional expression is a real challenge for many men. And a child whose emotional expression is acknowledged as being appropriate to the experience actually will have more self-confidence than if they're told not to experience that emotion. And so it's one of the biggest challenges I see in my work with firefighters and police officers is to give them permission to express whatever emotion it is and begin to learn how to identify the emotion. Because my sense is that often, when asked about an emotion, and it's important to be careful to ask about emotions because men often feel shame. Because if you ask them what emotion they're feeling and they don't feel it, they can feel shame because they're not experiencing what they believe the person asking them is expecting of them. And so that uh, it's my sense that when uh, participants say they feel nothing or they're numb, that is actually an emotion. And it may be the emotional experience of the emotion they were experiencing when they were told by a parent that they shouldn't cry or they shouldn't feel what they were feeling. So they very quickly learned that what they were feeling wasn't true, wasn't appropriate. And so that would be confusing for them. And they wouldn't necessarily understand what that was all about. And so it's
Mm.
uh, a lot of our work is to begin to invite men to experience and express their emotion and to identify the emotion that they might be experiencing,
Mm.
which is also a feature of treatment for trauma, is that often, and because I'm working with police and fire, there is a lot of trauma. And part of the trauma is that the event happened. Often the people are isolated or alone, and it happened, and they went into fight and flight. And what happened after that was they weren't given the support they needed because the emerging evidence has that one of the most important features of preventing PTSD is collaboration, support, emotional expression that's appropriate to the event. And if that carries on, it actually will prevent PTSD from happening. And that even knowing that somebody has your back is important to preventing the PTSD. So all of this also links to our work with our patients in terms of reinforcing ideas that emotional expression could be important. And what are the features that are contributing to depression with regard
Mm.
to experiences of their childhood and adult lives?
It's I sometimes say to patients, you know, I'm in your corner on this issue. And I think that can be very, you know, because I think as a family doctor, us supporting our patients, having their back really, where possible. I mean, yeah. But I was going to say, growing up in New Zealand and when I did, it very much was big boys don't cry. And the society, if you were crying as a boy, you'd be seen as a crybaby. So there'd be that sort of. I don't know if that was like that in Canada, and I suspect that's changing now. I think you know the more modern parenting, but of course you know there's a range. There's a range of parenting going on now, and some people repeating what they got as a child. You know, so it's hard. It's hard to change some of those things in a culture.
And often, theoretically, we would say that uh, sons fashion themselves after their fathers, and that the best predictor of how you're going to parent is how you were parented, and that generally uh, girls will fashion their relationships with other men after their relationship with their fathers. So that all of those are important features in terms of how seriously we take our roles as being the parent, the father.
And I must admit, in the work I do, when you see women who haven't had good male role models, they have trouble navigating safe men. They have trouble recognizing safe men. They end
That's
up
right.
getting into dangerous situations.
That's right. And generally, whether it's our relationships, we default to the familiar. I mean, that really has to do with the neural pathways that exist in our
Mm,
mind. Is
mm,
uh, even if the familiar is uncomfortable, we will fall to it until we realize that we're paying too great a price and begin to seek help. And I think
mm,
what you were saying in terms of you're giving your patients a message that you've got their back, and that especially if for family doctors, the value of the cradle to grave concept is to say to people that I've got your back on this, and this is a long-term relationship, so that
mm,
even if you come back to me 3 months, 6 months, or 12 months from now,
mm,
I'll still have your back because it
mm,
may recur, it may raise its head in a different way. And I really want you to know that regardless of how it manifests itself, I'll be here for you. It could be a very, very powerful message. And that actually means that you, as a physician, would be safe for them. And you may be
mm,
the only person or their first person that they actually feel safe with. And I think that's the value of primary care, nurse practitioners, nurses,
mm.
physicians. That's the longitudinal feature of this is what's really of value to patients.
Yes, I've met some young or adult women who've been in very abusive relationships, and it's hard for them to say who's a male they can trust, and I
That's
think
right.
sometimes as their doctor, if you're a male doctor, you might be the only one that they have to learn how to trust safe
And
men, basically.
I actually use that clinically. If people don't have a strong experience of
Mm,
trustworthy men or trustworthy authority figures, I will say to them, what's your sense? What's your awareness of what's going on between you and me right now? What are
mm,
you aware of between us? Are you
mm,
comfortable? And I would want you to be honest with me. How comfortable are you? And if people begin to say, well, I am comfortable here. I do trust you. And I'd say,
mm,
well, that's an important awareness of where in your body are you aware that you feel comfortable? Because the next time you're in a relationship with an authority figure, a man or a woman, uh, this is an indication of what safety is. So if this is not there, you might wonder what do you need to do to bring it into the relationship? Or maybe it's time to move away from that relationship because even the features of safety as you're experiencing them right here aren't part of the relationship.
I've got a few questions here, David. So saying I have your back is indeed a powerful message. However, how can we demonstrate this?
Just listening, right? That seems
Mm,
so simple, but you can do it by being that you have to be on call for everybody 24 hours a day. It means you can say, listen, I had a patient who really wanted to uh, have me be his therapist, and I said, the way our medical system works, there's not funding for this, and I'd love to do it, but he said, I don't care, I'll do it in 15-minute blocks. But I want to see you on a regular basis for 15 minutes. I said, we can do that. And so it's being creative and how can we be available to these people in
mm,
terms of saying just create a small C contract with them. So in terms, what would it take for you to know that I had your back?
mm.
Would it be
Well,
enough for?
literally, I'm saying to people, I'm in your
Yeah.
corner, has actually been quite helpful. You can see them visibly. We also at the mission had a male health coach who was quite athletic looking. He'd been a personal trainer, and so I was able to send this particular young woman to him. I said, "That's another safe male for you. You've now met two safe males coming from this terribly abusive upbringing. Her father went to jail for 18 years, so it gives you an
Wow.
idea of the level of abuse. But and she really got into very dangerous relationships with the young men. In fact, she's sworn off them basically, which possibly a safe thing in the short term. But
And you could make a contract to say, I'd like to see you every 2 weeks, every 4 weeks. Let's try that for 3 months or 6 months.
Yeah.
And just so that they realize that they're welcome and that they have some choice. So they have control also about how frequently would they want to see you as their clinician.
A question here. If someone demonstrates avoidance behaviors when trying to discuss emotion, is this due to lack of validation as a child? And how do we break through this?
Could very likely be a product of childhood and an absence of emotional regard on the part of
Mm,
the parents. So it's all about safety, and it may take a while, and to increase awareness, if you can begin to gently uh, invite a response about what's it like for you to come and see me. And what do they, and they might say, well, I enjoy coming, I like coming, it feels good. And then to begin to gently invite them to say, well, this might seem like a bit of a weird question, but is there some place in your body where you feel that? Is it in your chest, in your stomach? Do you feel, what is it that you're feeling? And can we give it a word? Once, if they can identify, can you give that a word? So that you're using their experience for them to learn about themselves, and then also again explore other things. And often I start with, there's different models of emotions and identity, how many there are, but I start with mad, sad, and glad. Are you glad to see me, and where do you feel that? uh, and does it make you happy? So to just be mindful and purposeful in your questions, and to also mirror them and say, I feel good when you see me, when you come and see me. It's good to see you. And I can feel that inside myself. It sort of has a sense of happiness, and I feel that in my chest. So that you're teaching them by being a role model. Uh, and it might take a while. Especially my experience of men is there's often I feel nothing, I feel numb.
mm.
And often in their jobs, if they're fire and police, they're to some degree they have to feel numb going into the work that they do, so that it's working to tease that apart. But just,
Mm.
it's a great question, and then just to move slowly and gently.
So another question here. Love the message, but we have to get them in the room first. What do you think is the best way to engage men who are reticent to engage with healthcare providers?
Yeah, I was afraid you were going to ask this question. I thought of this question.
Not
This
mine.
is
It's
my this is my job, and so we ask this a lot. So I think that partly we could begin to invite men to come in with their partners with pregnancy and with prenatal care, because there's emerging evidence that many of you will know this because of your practice, that for in terms of the prenatal contribution that a man gives the unborn child and the partner are three things. I don't do family practice anymore, but what I would invite uh, the mother to, can you bring the father of the child next time? Because I have some things I'd like to say to him. And what's important is for them to speak to the bump, is the men who speak to the unborn child, men who imagine what they're going to be doing with that child as the child grows up, and men who care for their mother. Those three features are really significant to the closer relationship of that fathers have with their children and to their families. So I think that as much as we have routine prenatal visits for mothers, we could begin to say, I'd like to, maybe not every visit, but every other visit, I'd like your husband to come with you, because there is a role for him. Because men generally say, there seems like there's nothing for me to do. Even in delivery suites, they're stand in the corner and watch. Uh, and how can we invite them to participate in the care of the mother and child? Because men who care for their children take better care of themselves. And that's an important feature of this work. I sometimes say fatherhood is a Trojan horse, because if we can get men caring for their children, they'll care better, they'll take better care of themselves, which could then affect morbidity and mortality. So the other thing that might be of value is the association that we work with, the Canadian Men's Health Foundation, actually has a booth at hockey games, which is our national sport. So they have a booth there where they invite men to learn about their health and then make recommendations about seeing physicians. It needs a lot, and we need to bring men, help them become aware of their tendency not to ask for help, to be independent, to diminish symptoms until they're very severe, and to normalize the need to see clinicians.
Got a question here from Sarah. She says, Kia ora, David, greeting you in Te Reo. What is your view on the role of patriarchal society on men's health and well-being?
Wow. Patriarchal society has done a lot of harm for women, and patriarchal society is doing a lot of harm for men. It's it holds us hostage to the illusion of what it means to be a man, and a belief that uh, men need to be in control. So it works against the very features that build families and community of asking for help, uh, acknowledging that life may not be as good as I want it to be, that I'm beginning to feel anxious, that I feel isolated, that I can't measure up to what it seems men measure up to who are really successful. And so that it serves very few men very well, but it doesn't serve the majority of men very well. And so I think also that there's an important understanding that uh, men's health, especially their mental health, uh, really isolates them, and it separates them then within their families and communities, and they need permission to be less than what patriarchal values would uh, have them strive for. So the going back to our study, uh, the children with positive relationship with their fathers, many of them said, my biggest wish is that I could have spent more time with my dad. He wanted to provide more, so he worked harder, and he wanted to provide things for us and vacations. But we would have been very pleased to just have them be around our homes more. And so that, what does it mean to have shared responsibility for providing, protecting, and teaching? I think we need to ask all of that. And this is a huge challenge. And it's because there are male-dominated uh, careers, and those are often very uh, macho, uh, thriving on uh, being tough, never showing any signs of weakness through tears, uh, definitely not asking for help, trivializing or diminishing the experience of other men. So it's a big challenge, and my sense of the globe at present is that we are being divided more and more in a very binary male female way that is not going to serve us or our children very well. So our work is uh, very much emphasizes the need to bring men into families, to bring women into the workplace with equality, and that what we need to collaborate rather than compete. We need to address, it's a great question, and we need to be aware of what's going on in the world right now in terms of the separation of men and women. It's not going to serve the next generation very well.
One of the things I've noticed with my children, one couple both have pretty uh, demanding jobs, but if the children are sick, it's my daughter who's expected to take time off work, not her husband. He was working environment. I mean, that's changed more recently, but one company he worked for, it wasn't okay for men to take time off for sick children, so it fell upon the women. And I'm sure a lot of our audience will be will be aware of that.
And
Um,
so that we are actually looking for an organization that will promote women in the workplace and support men who
mm,
want to take leave, who want to be the ones that take their kids to uh, uh, dentists and medical appointments. And we're going to be involved in a study by an organization, an international study by an organization known as Equimundo, where we're going to be doing it's mixed methods. We're going to do a survey as well as interviews to ask how do parents make decisions about division of labor and division of caring, and how do mothers and fathers care uh, uh, separately? How do they care differently? And how do they come to make those decisions? Because we're striving to create models of equality within the home and in the community, and looking for a workplace that will celebrate those different features of roles of men and women in the workplace. It's a very binary perspective, but we're looking for that opportunity.
The other thing you and I talked about before the show was we have a thing here called KiwiSaver, which is a retirement fund. And while you're working, you contribute to it. So when women take time off for childbirth, my daughters have all found they've slipped behind their partners because their partners have kept earning. So there's, like $100,000 difference in this retirement fund, which is going to make quite a difference at the
Yeah.
other end when they come to retirement. So I think those sort of things our society needs to be dealing with.
And I totally agree. It's why we're doing the work we're doing, and we've sort of got two branches. One is
Mm.
working very much with first responders, with police and fire, because we're looking at how do you change cultures from within. So we've established that the work we do with the frontline staff is evidence-based. There's strong indications that it's very effective. But we're also now looking and interviewing teams. So what are the ingredients of special services in the military, for example? uh, uh, because we really uh, want to understand uh, how do we uh, encourage, challenge, invite men to and organizations not to do what your daughters have experienced, but if indeed our children are important to us, and it's important that one of the parents stay home to care for them for a year, how can we then give positive reinforcement? How can we change the culture and give positive reinforcement by financially making sure that they don't lose while they're away? So there's what I meant to say by the work we're doing with first responders. We're now working involved at a policy level, and our goal is to also get there in terms of the work we do with fathers, fatherhood, men, and masculinity, to get to a policy level about how do we change this within organizations, within government, so that there is equality. Should uh, women take the year off, they shouldn't be penalized financially for it. Uh, and what would be needed to bring that about? It's not going to happen overnight.
One of my daughters and her partner did a financial transaction to balance things up, which I thought was very sophisticated, but it'd be very hard to sort of do that on a public basis. Got a few. So I got Rachel's just said very interesting talk and such an important subject. Thank you. So that's great. Thank you, Rachel. So how do you reach a man who has not experienced emotional care support as a 5-year-old and will not seek help from any healthcare professional?
Well, it has to. If you're not in the man's presence, uh, you're not going to get access to his emotional expression. So it is the work we're doing. We look at fatherhood in three different categories. We look at the biological and adoptive fathers, where there's a huge sense of accountability. So I have two children. They are the only two people in the world that can call me dad. So my responsibility to them, they're adults, they're in their 30s. My accountability to them as children in that generation is higher than to anybody else. So then we look at another category of fathers who are our mentors and coaches. And we realize that they have influence on more children and do have some degree of accountability. And my sense is that that's where we want to go. That's our goal, is to get there with regard to your question. And I'm going to come back to that. And the third category is our parasocial fathers. So those would be the Andrew Tates of the world, Jordan Petersons of the world, uh, who have a mass following. I think Andrew Tate has millions of young men following him. So there's zero accountability and an incredibly powerful message. And my sense is that if children don't have a strong mentorship, a strong relationship with a father figure in the other two components, they're more vulnerable and susceptible to the message of the third. So my hope would be that should the father that you're making reference to, is there some way through coaches or mentors that you could get access to him so that the coaches, we've worked with high performance teams, Stanford soccer team, we've worked with the university football team here in Vancouver at UBC. And our work with these teams is not to be coaches of the sport. Our goal is to be coaches of them being honorable citizens. And so that being honorable citizens involves all of what we've talked about. It talks about responsibility, it talks about accountability, we talk about consent and respect of each other. So, and we also in that work talk about emotional experience and emotional expression. So if a father is totally isolated and not taking that child to any activity, it's going to be really challenging. And the ongoing request would be to invite the mother of the child, if the couple are together, can you bring your husband with you sometime? And then just uh, make sure the environment is safe and comfortable enough for him to want to come back a second time. And then the other part of what we're working at is getting to programs of coaching to teach coaches about working with other coaches in creating an environment where they encourage kids to become honorable citizens. It's not an easy task, and there's not an easy answer to your question. But to be certain that you're always available and don't tire of the invite, of the invitation, and to just keep inviting the father to come back. If I don't know, when I was a family doc, I did house calls. I don't know if house calls are trendy at all or whether people do them. That'd be another opportunity, is to say I'd, do a house call at some point to just uh, give the father some sense that you're a safe and comfortable person. And the other thing that I've learned is that I've got to stop talking doctor jargon and just use the language, and you all know this, use the language that the people use, so that I'm working to separate the hierarchy, the power differential, because I do hold the power of as a physician, as a clinician. And how much of that am I willing to give away in the way I communicate with the patient?
I've got a sort of slightly curvy question here relating to some of what you just said. I'll just read it out. Most behaviors need balance or they can become maladaptive. Can being emotionally intelligent, while essential to a point, also become excessively relied on at the cost of resilience and maladaptive mindset. There is a feeling amongst the older generation, the generations coming up aren't resilient, perhaps. That's just me adding that in there. So how would you answer that? Is there a risk of being emotionally intelligent as a male going to make you less resilient or adaptive?
Our programs for the fire and police are based on resilience. And we look at the definition of resilience as the sense of well-being. And there's a lot of features that contribute to resilience. There's the uh, there's the physical, biological, there's the family dynamics, there's environmental, there's cultural, right? So that re- and resilience can be challenged at any time by the circumstances around us. If we have an internal illness, our resilience might be compromised for a while. If there's a relationship issue in our families, the resilience could be compromised. And right now, there's a uh, uh, resilience is Canadians are full of anxiety now because of the new leader in our neighboring country, and it's affecting everybody in this country because of the threats that have been made. So that's very environmental, right? And climate change is environmental, and all of those features can come at us with resilience. And what do I need in terms of the essence of my own well-being? Do I need support? Do I need conversation? What can I do with this? And uh, I have yet to meet a man where emotional expression was maladaptive. The I see it through a slightly different lens in that the uh, inability to express appropriate emotions is maladaptive. It results in isolation, depression, anxiety, uh, uh, and uh, and isolation. Uh, so that uh, in my work, I make every attempt to invite men to go beyond anger. There's two emotions that men get celebrated for: emotional, sexual excitement and anger. So if you look at anger is regarded as a secondary emotion. Anger is often expressed in the place of shame, fear, and grief. So that, uh, and it's what men get praised for in terms of being angry. And if we can work with men to experience the other features, and when I'm told as a little kid I shouldn't cry, we got an issue around grief. And uh, depression for men could actually be angry. It could be expressed through angry. It doesn't necessarily have to be expressed through sad. And that's why it's really important for us to watch the young men, the age 19 to 29. Are they depressed, and how is it manifested in their lives? So it's really important for us to understand the complexity of emotion and yet the simplicity of it, so that it's more experiencing the appropriate emotion for the events in our lives that will uh, benefit the mental and psychological emotional health of men. And rarely would it be maladaptive, unless I'm missing something in your question.
Yeah, no, that sounds good. Just coming back to relationships, how would a son's relationship with his father affect his adult relationships in adulthood with a woman? So
Uh,
presumably it would be things like respecting women, valuing what they did, that sort of.
they, that's right. The way the father treats the mother of the child is significant. But in some instances, the mother of the child and the father may not be living together. So
Hmm.
that actions speak louder than words, and the way the father relates to women will be likely the way the son relates to women. And my sense is that as fathers, we have the opportunity to teach our sons about being in relationship with others, men and women. I'll, we were invited by the Stanford soccer coach to come and work with his team. And he said, "Don't you dare talk about the pitch." And I said, "No, we're not going to do that." He said, "I want you to talk about what it means to be an honorable citizen, as I mentioned earlier." And it seemed a little strange at first, Stanford being in California and us being Canadian. And my age makes me look like a father. And for them, some of them, they probably thought I looked like their grandfather. So it took a few sessions. We had 4 1.5 hour sessions, and we made sure that we didn't do any of the really intimate work until the third session because we wanted to have them get to know us and understand that we were working with them. And we actually had more exercises of participation than we did lectures. So our third session was focused on relationships, and it had to do with consent. But we also looked at consent at a bigger, from a higher level, but what about the consent for extraction of minerals from the earth? What are we have we gotten consent from nature itself? But then in the end, they were more interested in consent with regard to their intimate relationships. And it hadn't been gone on for long. One of the soccer players put his hand up and he said, "You know what? I'm in a relationship with this young woman, and I really like her." And he said, you know what? In terms of consent, it's hard for me to talk about, and I really want to be in a relationship with her. I want this to be more than a sexual relationship, but I don't even know what to do." And I said, "So why don't you be her and I'll be you?" He said, "In front of all these guys?" I said, "Yeah, let's just do that right now." And I said, "So I call her, I don't know, Mary. So Mary, I have a conversation I'd like to have with you, but I don't even know where to start." And he said, "You do that?" I said, "Yeah. If you want to be in a relationship with somebody, you have to be honest. You have to be vulnerable. You have to tell the truth. Because in telling the truth, trust will be established. And if you're vulnerable, there also will be a sense of safety." Those are the messages fathers need to teach their sons. Is how do you have intimate conversations with women that you care about? How do you have intimate conversations with anybody that you care about? And it has to do with uh, understanding the rudimentary features of a meaningful conversation, which could be as simple as a father saying to his son, just when you're with somebody, be curious. Make sure you ask questions. Ask questions you know, about events, about how, when, where, what. It's very simple, and I would say, and avoid the question why, because the question why always often makes people defensive. So I think that what's important for that father-son relationship with regard to the son's relationship with women, presuming they're heterosexual, uh, is that fathers teach their sons how to talk to women, and to understand that they might be very different from one another, and be curious about that, and teach them how to be safe in themselves and safe in relationship. And because the evidence would be that the sons will treat women the way their fathers treated women. So as fathers, we have an opportunity to demonstrate another way of being.
Couple of general questions here. One about, so I'll read the two of them. Besides social media, are there any other hypotheses that could explain men's mental health decline? And then a co-question, do you think globalization contributing to loss of traditional supports and tendency of widespread immigration travel in younger men perhaps are contributing to these issues?
I'm going to start with the second question. The study that was done in Canada definitely would reinforce the model of that immigrant uh, male immigrants have a higher tendency to depression and anxiety. And you know what? It's I think there's a few components. One, it's important to realize that uh, boys uh, mature more slowly than girls, so that in terms of the prefrontal cortex and executive function, that they are not mature until they're 25 to 30. And so that what is it that we expect of them? Often we expect them to make decisions about careers, about uh, relationships, and they're not there yet. I think that with regard to Canada and particularly Vancouver, this is an incredibly expensive city to live in. So somebody who is in his early 20s and sees the home that he might have grown up in is virtually unattainable. It's unaffordable. So what's he going to do? In terms of so he has the career choices to be concerned about. He has relationships to be concerned about. He's has an identity to be concerned about, and that's true of uh, immigrant boys. Who am I? I don't live in the country I lived in anymore, and I live here, but where do I belong? And the whole essence of uh, suicidality. I'm going on a bit of a tangent, but there is a higher rate of suicide in men. I use the model of a Joyner where he talks about uh, belonging, burdensomeness, and comfort with death are features of suicidality. So if somebody doesn't feel like they belong, it's one of the three uh, uh, features that could contribute to that. So that your question about immigrant, yes, their sense of belonging is compromised. The sense of belonging in another culture may have a very different framework than it had from the world they lived in. Uh, and so that I think those are also common features for uh, young boys generally, is that it has to do with maturity. It has to do with girls are, uh, as is true in Canada, I'm sure it's true in New Zealand, that there are more girls going to secondary, post-secondary education. So boys feel like they're left behind, and they don't have the role models. Uh, Some would say men have a sense of feeling needed, so boys don't feel needed anymore. So what can we do to bring them in and to let them know that they're important to families, they're important in relationship, they're important in the workplace? I think there's a whole shift that needs to begin to explore how do we keep young men, how do we get them involved, and then how do we keep them involved, and how do we understand their expressions of anxiety and depression, which might be quite different from conventional ideas of what that might be. You know, it's not unlike uh, MIs in women are quite different than MIs in men. But for years, we all believed it was the elephant on the chest. And women don't necessarily feel that same feature when they're in the middle of an MI. And I think we need to ask some of those similar questions: is do young men experience and express anxiety and depression differently than what we might expect or anticipate?
Somebody had a question. What were the other two features for suicidality? They don't belong.
There's three. One is a sense of belonging. The second is burdensomeness. So it has to do with my family would be better off without me.
Mhm.
And the third one has to do with comfort with lethality. So everybody on this webinar who's in healthcare is already at a higher risk than the general population, because as healthcare providers, we are exposed to death, and we will over time have more comfort with death than we might have had before we started this profession. So that uh, in the non-healthcare providing profession, one would look at comfort with lethality. Somebody that uh, buys a motorcycle, buys a faster motorcycle, then starts boasting about how fast he's going. Then he starts boasting about how fast he goes on a winding road, how fast he can go when the road is wet. And it's not necessarily a conscious comfort with lethality, or it could be an unconscious thing. So it's really important, and we teach this to the fire and police because they're uh, especially with firefighters, we got involved in this work because the number of suicides that were going on, and we just say, listen, here's some things to listen for. Is to listen for them talking about they don't belong anywhere, they don't fit in at the fire hall anymore, they don't fit in their families, and that their families would be better off without them, and maybe even some of the uh, fire teams would be better off without them. Those are indicators that things are uh, need to be explored.
Yes, I think burdensome is a particularly potent one, isn't it?
Yes.
If you
Yes.
think, um, from actually one of the early questions was, does your work cover domestic violence and aggression? Janet Fanslow, who's actually a researcher on domestic violence in New Zealand, has published some pretty scary. We're actually a pretty violent country, male to male and male to female. We actually are fair way up. There's quite a bit of violence here. How does your work uh, get involved with that aspect of things?
Yeah, that's a really good question. And it's one that we've struggled with. It's one that organizations have invited us to look at very closely. And some have felt that we're uh, not really doing what we need to do. So we don't have a primary focus on violence. However, we are very clear in saying that our goal is to work upstream to prevent violence, so that when we work with fire and police, it's actually been our experience that in a number of instances, people have talked about their childhood abuse and childhood violence for the first time ever in their lifetime while we're doing this work. So we really say to people that, it's that's a predictor. If you've experienced violence, you have a greater likelihood of being violent yourself. So we integrate it into the work we do, but we don't focus specifically on violence against women or violence against men. Our intent is to work upstream so as to prevent the violence.
I wonder if we can just going back to the beginning. Is your organization is called Blueprint? How
That's
did
right.
you get that name? And somebody wants to have more of you, David. So I was wondering about what's the best way to find out about your thinking? You've got those podcasts you sent me. Are there any other way that people can find out the words and thoughts of David Kuhl?
Some of them will be on blueprint.ngo. We're working hard this year because we're getting asked that question. So our goal this year is to get information out there, and it's partly why we're now closely associated with the Canadian Men's Health Foundation. They're going to help us get our message out there in bite-sized pieces because it is our intent to do that. We started off as the Men's Initiative and had already become known as such as an entity. But then, as I was reading more and more of the literature, uh, the Men's Initiative is TMI, which is also the abbreviation of traditional masculine ideology, which is the very thing that we're working against. So we decided we would change our name and did an extensive study and look at it. And I came across the writing of Bell Hooks, who's an Afro-American feminist who wrote a remarkable book on masculinity. And this isn't a direct quote, but it captures the essence of what she was saying, where she said, based on her relationship with her father and the men in her family, she said, men need to learn to love. Men need a blueprint in order to know how to love. So once we saw that, we decided, and we regret now that we didn't make it plural. We don't believe there's one blueprint. We believe there's many blueprints. And our goal in the work we do is to invite men to live by a different blueprint than the one we're living in. Something has to change.
Um, Anything else you would suggest the audience might like to look at? Books?
You know what?
Um,
At one point, you asked me about you asked me about three books, and there's many more than three, but some of you may have realized that I'm trained in Jungian psychology, so I have a Jungian bias. And it was actually Bruce that introduced me to a Jungian analyst by the name of James Hollis. And one of the books he's written really has influenced me a lot. Uh, he wrote it some time ago, and it's called Under Saturn's Shadow: The Wounding and Healing of Men. And he does a great job of introducing the ideas of where woundedness comes from. And the beauty of the book is, I think he talks about 8 secrets that men keep, but at the end of the book, he talks about the 7 ways of addressing the wounds of men. So it's probably 20 years ago, nearly, that I read that book for the first time. It's still relevant, and I still go back to it occasionally. There's a lot more books now on men, and the other book that got me started was another Jungian analyst, Absent Fathers, Lost Sons. That book also got my attention, but that's by Guy, as in Guy, Guy Corneau, Corneau. Both of those are old publications, but they really got my attention decades ago before I decided I was going to put my stethoscope down and actually focus on this work. So, and then because you asked me about three books, uh, I think everybody ought to read Man's Search for Meaning by Viktor Frankl, because he states quite clearly about things that are important, or the book I Thou by Martin Buber, but that book is harder to read. Uh,
so any closing remarks? We're coming close to finishing. Um, would you like to make any closing summarizing remarks?
I think that all of you are in a great position to contribute to significant change. Your awareness, your interest, your curiosity about the health and well-being of men. Uh, Most men want to explore how they can be different, how they can be part of their families, and that you know, often, I guess I don't really want to open another can of worms, but I do want to say that toxic masculinity is in North America a very uh, popular term, almost so much so that it's become one word. And if we as healthcare providers and clinicians can begin to see that masculinity in itself isn't good or bad. It can be actually if men provide, protect, teach, they can have a very positive role, and that the features and the labels that have been given to men recently aren't adding are adding to their shame and their isolation. So that just to welcome them into care, welcome them into the unit of family, welcome them and to let them know that they are as important, they are very important in the development of their children, starting prenatally and early on. And so that uh, all of that, I think, can shift to bring the units of care closer together. And hopefully, our goal is to uh, reduce morbidity and break down the difference in the years of mortality that visit men earlier than women. It's a public health crisis. So you're part of that and you're in a good position to begin to address it in a new way.
So I think
Yes.
we'll call it a day there, David, because I realize it's very late your time. It's 11. What time is it at the moment?
It's quarter to midnight.
Quarter to midnight. Well, we thank you very much for doing this. Lovely to see you. So thank you very much.
Thank
Spectacular.
you. And all the best to those who are watching.